all over again. I didn't touch the correct button.
Let's do it.
And so let's begin again.
Okay.
We're live now.
Okay. So I'm going to say again, good morning, Dr. Rosensweet.
Good morning, Carolyn.
And I'm going to start out again by saying thank you so very much for that amazing, amazing interview you did with the amazing, amazing Jim Hernser.
Yes, he's a wonderful, wonderful person and one of the most experienced and knowledgeable prescribers, providers that I've ever met in my whole career.
Oh my God, yes. And as I said, I know a little bit of the backstory of when you went to NASM and you met him and you guys walked and walked and walked. And now it's very apparent to me as to why you guys hit it off so well. I mean, it's obvious. And
yeah,
for us women, that interview, as I just said, I think that it should be submitted to the Smithsonian Institution and be there forevermore. It was that special. And it made all of us feel so warm and fuzzy and happy and safe and secure and like they're people that really have our backs, you know? And
that's so great.
I cannot tell you. I mean, the emails I get, the posts I get, oh my God, that thing was off the charts. And so please, whenever we can, let's have him back. I mean, that was just so fabulous.
That's a very interesting perspective to hear from you, that to know that he's out there doing what he's doing and to know that someone has your back. And I want to tell you, Jim Hernser and myself and several others, the amount of time and energy and care and effort that he has put into protecting compounded bioidentical hormones from disappearing because of the FDA. And we invite you all to go to the coalition, the CBHRT Coalition website, to start learning about what the FDA has in mind here. And also, and to let's communicate with the FDA, because ultimately it serves their main mission to have good medicine practiced. And so there's going to come a time where there's going to be a lot of communicating back to the FDA. And also there's a new website coming up very soon that we want you to see, and we'll announce it next week. It's WeTheWomen.us. And at any rate, yeah, Jim Hernser.
Boy, what an amazing guy. I mean, you're an amazing guy. To have him with you, it was just absolutely phenomenal. And I truly believe that it has helped women to feel so much more safe, knowing that two amazingly incredible men, well-educated, absolutely do have our backs. And I loved, and I'll say this and I'll get to the questions, his PTSD, taking the D out of PTSD. Boy, did I throw that one out on my Facebook page. That is so important. No disorder. And I know you're a wordsmith, and I know how you are very.
I thought that was a wonderful thing to do.
Indeed. And I will never, ever use those 4 letters together again, ever, you know? Especially for our veterans who, oh my God.
Yeah, my God.
Yeah. No one needs to be told they have a disorder, you know? No. So anyway, welcome, and welcome to the women. Hello, Facebook user, and everybody who's going to be coming up. Question number 1, Dr. R. Why does Dr. R say that progesterone is not only safe, but beneficial in surgical menopause? When Dr. Blooming and others, Dr. Blooming, Estrogen Matters, and others say it's better to have ERT alone without bioidentical progesterone in surgical menopause. I don't mean synthetic versus natural. I mean even bioidentical progesterone too.
And as you know so clearly, I have very, very strong feelings about this.
I do know.
And it's like anything in medicine. We keep learning things, and how much we knew a while ago can turn out to be not the best knowledge, and not using progesterone is the best knowledge. I mean, using progesterone is the
Music,
best
yes.
knowledge.
No, no, no.
And one of the reasons is we tend to think of progesterone along with estrogen and testosterone as ovarian hormones, and thus related to female functions. And indeed they do. But they have universal effects on almost every cell, tissue, and organ in the body.
So
For
not just the
example,
uterus.
absolutely. For example, there's many young women who are strong and out living good lives and meeting the challenges of life, and they get into their 30s and they start developing something that they're calling anxiety. And it's a bit of a surprise to them because, yes, they have feelings. We all have feelings, but they never would consider themselves to have anxiety. And one
Where
of
you
the main
can't walk
reasons
out the door.
and one of the main reasons is that their progesterone levels have fallen. And progesterone is the great calmer, and they start taking progesterone and they're themselves again. And that's the comment. I'm myself again. Progesterone is affecting mood big time. Progesterone is the great calmer, affects sleep. So as women lose their progesterone, they start having one of the major hormonal origins of sleep disturbance. Woo! Who needs sleep disturbance?
No.
Progesterone is very profound for that. Progesterone is the only biochemical that I know of that promotes the function of the osteoblasts. These are the cells that lay down new bone. And what you may not know is bone is far from being fixed. It's a very metabolically active, and it's constantly being dismantled and refurbished, replenished. New bones being created, and progesterone is the one substance, again, that stimulates the function of the osteoblasts, the cells that lay down new bone. Progesterone, everywhere important. Now, the old belief was that progesterone, progestational, related to pregnancy and related to the uterus. Therefore, if a woman had a hysterectomy and had her uterus removed, why would she need progesterone anymore? And indeed, progesterone does have a profound effect on the lining of the uterus. With no progesterone and unbalanced estrogen, you can get a lining that's too thick in that uterus, and you need the balance of progesterone in the uterus. But the belief that no uterus, no progesterone, no. The answer is all women, every single woman on the planet, with very, very few exceptions. Those who are totally sensitive to progesterone need progesterone. It's wonderful, and we should be taking it. You should be taking it your whole life, starting probably in your 30s or at least your 40s.
I agree with you, and I asked this question prior to us restarting. No, Bijou, starting. Like why doctors? Oh, I'm so sorry about the cat. Oh, Bijou, go. Oh,
it's okay. That's fine. Let's enjoy her.
Okay, thank you. He's going to scratch at the door. I'm figuring it out with the green screen and all that. Anyway, why are doctors so, in this word I can't pronounce, vehemently opposed to giving a woman who has had her uterus removed, an oophorectomy, cervix out, everything else? I mean, they literally are just like,
I know. Well, you don't know what you don't know. And medicine, like every profession, has amazing, wonderful, devoted, dedicated people at every single level.
Yes.
From manager in the hospital to clerk to neurosurgeon. There is phenomenal people. These are my special tribe. I've been born into that tribe, and I know so many beautiful, devoted people. And then there are others. Mm-hmm. And they're not ruled so much by what it is to be home in themselves and as a wonderful human being. They seem to operate more out of thoughts and feelings that are polarizing and antagonistic and taking stands. And when you look into these folks, also the ones that oppose progesterone, what you know about them is hardly anyone is specialized in menopause, and they really know a great deal about the hormones. And gynecologists who do amazing things for us, very few of them have gotten super interested in the biochemistry and biology of hormones. And so these people are taking these strong opinions without having done the research, which is, well, this is one of the challenges we're all facing, is how do we meet up with the polarization that's occurring and everywhere that is occurring, and sit down and talk and listen and listen and listen and go for the truth. Learn, go for the truth. So yes, I am aware that there's been a long-standing opposition by some, certainly not all, healthcare providers against the use of progesterone in women that have uteruses, that don't have uteruses. But I'm going to state a very strong opinion once again. All women should be taking progesterone, uterus or no uterus. All, every. It's very important for your brain, for your sleep, for your mood, for your bones. Some women, progesterone is very important for libido. All sex hormones are important for libido. In some women, it's progesterone that leads the way. So I'm going to take a strong stance and give you my best opinion, and then you all figure it out as you reach out and try and discover what makes sense to you.
Okay. Yes, and back to that teamwork, which is always so important. Doing the doctor shopping, hooking up with someone good, and then you got a great thing going, as far as I'm concerned. So a question just came up. It says, is progesterone used orally or can it be used topically? So my next question is, why is it that estrogen and testosterones are a no orally? However, progesterone is okay orally.
Excellent. And we can bundle those together.
Indeed.
Let me start with, when you take a hormone, and these hormones are fat soluble, when you take them orally, they go through the stomach into the small intestine and they're absorbed. And as they're absorbed, they go right to the liver directly. And then a huge percentage of that steroid hormone immediately gets processed in the liver when you take it orally. Some of it makes it through the liver unprocessed, unmetabolized, and then gets distributed to the whole body. But most of it's metabolized, maybe up to 80–90% of an oral steroid. So that's about oral ovarian hormones, period. And then they all behave differently. Testosterone orally can injure the liver. So forget about it. There is no oral testosterone as far as I know. You can't get it, and nobody should be making it up because it can hurt the liver. It's not going to hurt the liver in all people, but it can hurt it in some. And if it's hurting in some, it's probably not helping anyone else's liver. No oral testosterone. Forget about it.
And we need our liver.
Estrogen? How about oral estrogen? Well, estrogen can be taken orally, and my God, tons of it were given out in birth control pills. And the initial hormones to treat menopause, the most popular ones, were given orally. But here's the deal. Oral estrogens can provoke the coagulation mechanism and make someone hypercoagulable. Huh? Well, we knew this from the birth control pill because a certain small percentage of women who went on the birth control pill, and the birth control pill is a pill, it's oral, and it's got extra estradiol in there. It's got estradiol in there, the most potent estrogen. And we knew that a certain number of women would get thrombophlebitis. They'd get a clot in a leg vein. And some of those women would have that clot break loose and go into the lungs and cause a pulmonary embolus. And some women didn't live through that. And we knew that that complication was there, but, you know, the birth control pill is still being given, of course, and it's a rare one. But, you know, I've practiced long enough, 25 years with women in menopause, to meet up with women who had that blood clot in their lower extremity, and even women who had a pulmonary embolus. So the coagulation mechanism is very delicately balanced. If you get hit by a spear, you want to be able to clot. So you want to have the ability to clot. But if you're not, if you're just walking and talking around the planet Earth, you don't want to clot inside your own vessels. So you got to be uncoiled. It's delicately poised, the clot mechanism. And what does estrogen do? It moves it over towards more propensity to coagulate. So why in the world would you give estrogen orally when it can do that? And estrogen can also promote inflammation. And this is not something we need, is excessive inflammation. So for that reason, I never give oral estrogen, except one exception in my whole life. And why do that? And especially since estrogen absorbs beautifully from the skin. It's just amazing how well it absorbs. As I've got evidence with 1,000 24-hour urine hormone tests to see it absorb in real time. And then progesterone, the other thing, in order to get adequate estrogen doses, if you take it orally, you have to give higher doses, because 80% of it or so is going to be knocked out in the liver, metabolized in the liver. You're going to wind up with all these estrogen, extra estrogen metabolites, which you do not need. So you get higher doses. And Dr. Jonathan Wright has written a beautiful article about that estrogen should not be given orally, but that if it is, instead of giving 1 or 2 milligrams, the most that you should be given is a 1/4 milligram, because then you don't wind up with these huge levels of metabolites. Now, he is not an advocate. He's not advocating the use of estrogen orally, but he thinks that a lot of the problems that occurred from oral estrogen came from the high doses you needed to do to get decent blood levels, because it first passed through the liver. So I know that's pretty much in the weeds there, but that's a more complete story. Progesterone is fine orally. It doesn't have problems associated with orally, and millions of women have been treated with oral progesterone. And sometimes we want to turn oral progesterone because a woman's body puts out 100 times more progesterone than she does estrogen.
Interesting.
Goes back to the first question. What is it that seems like nature seems to favor progesterone very profoundly? And so, I like to respect those things. When nature's putting out 100 times more estrogen than more progesterone than estrogen, but there might be a use for it. And sometimes we can only get the topical progesterones only so concentrated. 200 milligrams per milliliter is the absolute max, no matter what vehicle you're using.
Yeah, right.
What carrier you're using. And so sometimes we turn to oral progesterone because we can get higher doses. And then with oral progesterone, there's a metabolite that has special benefit for sleep. So we'll frequently turn to oral progesterone in place of topical progesterone. I always start out with topical progesterone because it works in a lot of women. But about 2/3 of the time, eventually we switch over to oral progesterone. We can get the doses high enough, because really when we can benefit sleep and mood, we want those higher doses that we can achieve orally. So oral progesterone is great. And then even DHEA can be used orally. That's all I have to say. But I like DHEA topically mixed with the testosterone.
Cool. Nice opinion. Not strong. So I want to welcome in our Facebook users, Karen, our Facebook users and Facebook users. They all have names. They just don't show up on here, which is strange. And Karen did say, too many negative metabolites. So interesting. So this comes in, is there any benefit of taking phytoestrogens or essential oils, supplement products?
Well, menopause and the many symptoms and biological changes that are associated with it come from a very specific biochemical deficiency called hormonal deficiency. And the other substances you named, they don't behave like the actual hormones.
Right.
And, you know, I have never yet met a person, and maybe someone does exist, that really got the kind of relief and the kind of long-term benefit to muscles, bones, brain, arteries, lots at stake when you lose these hormones. So I'm just not an advocate of these other approaches in any way, because the consequences of not having these hormones, they're very severe. There are
Yes.
major increased risk of cardiovascular events like heart attack and stroke. There's a real risk to many women to dementia. There's almost a certain loss of muscle that leads to cane walkers and wheelchairs and assisted living facilities and nursing homes, all of which,
And
in
diapers.
almost every case, can be prevented by administering hormones and not these other substances, supplements, oils that are suggested, unless someone will illuminate me. And no one has over 25 years. They're all to me, they may provide some symptom relief, but the consequences of no hormones is humongous, just like it is in men. When men lose their testosterone, there are tremendous adverse consequences that occur.
Oh, yes.
And who knows it? The 90-year-olds, or those of you who know the 90-year-olds, or the 80-year-olds, and those of you who know the 80-year-olds and are paying close attention to the walking and talking and thinking and energy and libido, if you have any knowledge of that. The consequences of not having the hormones is humongous, and the other stuff doesn't do it. Strong opinion, once again. Take the hormones for your whole life. Go to an expert, get it good when you're young, and take them for your whole life.
Right, because as you've taught us so many times, hormones are extremely powerful biochemicals that we need. We've lived with them our whole lives. I mean, they don't have to be exactly sex hormones per se. Hormones, just hormones, are really strong, and we need them. And when we lose them, we feel it. Boy, do we feel it. So thank you very much for that. And I'm seeing the questions. I'll get them, and I'll get to them eventually. My third question is this. Recently, this is a big one because I get this a lot. Recently, I've started to get short of breath episodes where it feels like my belly is over full and I cannot get a good breath. I had a cardio workup and I'm fine. I don't like that word fine, but anyway, she had the cardio workup and everything was good. Is this more menopause fun? I am struggling with episodes of very low estrogen and not being treated yet, begging for estradiol patch, and I'm only taking progesterone cream at night, but this air thing is really driving me crazy, she says.
I'm glad you're investigating, if I heard that question correctly, with a cardiologist.
Yes.
Would be a gateway to a pulmonologist. And I'm just not, in all of the 25 years, I've not run into a patient who's had significant short of breath related to menopause. So why I want to answer this question is sometimes these symptoms, if they're not easily alleviated, and many are, by treating a woman's hormonal deficiencies, surprises happen and symptoms that you think would be unrelated disappear. But it does bring up that when they don't disappear, we have access to medical experts and hear heart and lungs. And when I hear short of breath, it really taps into my knowledge as a physician. And if I heard that in the opening consultation, I would listen very carefully. I'd ask a bunch of ancillary questions around shortness of breath, which I can't do during this kind of venue.
Of course.
I learn a lot, and I would learn a lot, and I would make a decision right there. You know what? We can pause on this, treat the menopause, and see if this goes away. There's nothing really clear here, and there's nothing really severe. Or I would make a different type of decision. I'd listen to that history. I would really zero in my microscope on that shortness of breath, and I'd go, whoa, this is the kind of thing that I want an immediate referral to a cardiologist or a pulmonologist, at least for the evaluation and the assurance here. And so it points out the same thing over and over again, that a woman's job is to find a healthcare provider that specializes in menopause. And also anyone that does has at least had the training in basic medicine. And it makes a big difference, because the very first thing that happens traditionally in any kind of consultation is a very thorough medical history is taken.
Mm-hmm.
When you get an alarm bell, like I get short of breath and it's severe, right then and there, a good healthcare provider is going to take note of that and take action on that.
Because we do need to breathe.
And really track a symptom like that down. And when a specialist is needed, the patient gets referred. So it's all part of the standard intake procedure of someone who really knows what they're doing, who's licensed and trained and experienced. They will ferret that one out. And it does point to the fact that not everything that goes on in midlife is menopausal. It's related to hormones, and it's a time of life where other things can happen, and you want to get a healthcare provider who's savvy enough to pick up on it and go, let's handle this one independently.
Yes. I mean, there's something to be said about full belly and bloat, and women ask about bloating, from hormones, and that's kind of visiting a little bit of a different subject. But in this question, it kind of seems to go hand in hand, with big belly and feeling overfull, unable to get a deep breath. I've had that if I've overeaten or what. I'm like, I just can't seem to feel myself. But point well taken. Absolutely. And she did visit a cardiologist. Thank you, God. So thank you for that answer. The fourth question is, since estrogen binds to T3, which is active thyroid hormone, thyroid binding globulin, do most need to increase their thyroid dose when using Biased? I know that this is very individual, but do you have any thoughts on that?
Yes, it's an important one too. There's many, many women that are on thyroid hormone replenishing for good reason. I mean, the thyroid gland is called upon to do a lot of action, especially in stress. And when you do it for years and years and years, the thyroid gland can lose its youthful vigor and not put out as much hormone. So it's very common for something called functional hypothyroidism. It's not a frank hypothyroidism where it's so obvious that someone has nowhere near sufficient thyroid gland, and that can show up in symptoms very well, in physical signs, and also on testing. Now, that's what most people think of as hypothyroidism, but there's now thousands of healthcare providers who are aware of functional hypothyroidism, where the thyroid gland is just not putting out the thyroid hormone with the level of vigor that really serves metabolism and the health of the patient.
Right.
We're able to identify that through a real thorough medical history, as well as some sophisticated thyroid blood tests. I'd like to enumerate those for you, for any of you who are taking notes. In order to properly evaluate a thyroid, you need at least this, blood test-wise: TSH, free T3, free T4, and reverse T3. You want those in the blood test. And and back to the main point is that there's a lot of women who are on thyroid hormone when they enter menopause. And then they've gotten into lower estrogen, and when you give them estrogen, you can change the nature of the binding of thyroid hormone and estrogen. And meanwhile, you can change the balance, and maybe you'll need to change the dosages on thyroid hormone. So somewhere along the line, if a woman's doing fabulous, we don't immediately zero in and retest the thyroid. But if somewhere along the line in treating with estrogen, progesterone, testosterone, and DHEA, if we're going to be asking about symptoms that could relate to proper thyroid function, and if we get a hint that the thyroid might need adjustment, we do that blood test called free T3, free T4, TSH, and reverse T3. So yes, they are related. And many women in menopause who are on thyroid need to have their thyroid doses inspected and adjusted somewhere along the line when they're being treated with the ovarian hormones.
So I'm going to throw this in myself, kind of selfishly. When we take hormones, we're not making hormones, but we're taking them. Do they still tend to fluctuate as they did when we were taking them?
Well, hormones are recruited for a lot of different needs. They're the basic needs. So when you're taking ovarian hormones, for example, your estrogen has profound and all over the body functions, and so does the progesterone, and so does the testosterone, and so does the DHEA. However, if you're highly stressed, you're going to trigger a whole biology, the fight or flight biology.
Saber-tooth tiger time.
And at the vanguard of the fight or flight is adrenaline and cortisol. But they're not the only hormones that participate in the stress response. For example, estrogens and testosterone really are excellent for the stress response, and they are recruited. So this could account for some variation in the dosages, subtle variations you may need in the dosages. If you're going through a period of profound stress, you may need to adjust your dosages. You'll probably get a clue, at least many women will, is, God, you're starting to get warm rushes again. And the dosages that served you so well last week, this week, when there's heavy stress challenges in your life and you're getting warm rushes, you may need a little more estrogen. It's one of the reasons we love for women to get a feel for these hormones from the inside. And when you're using the organic oils, it's very easy to adjust the dosages you need. And that's why we wrote the book, is we want women to get a feeling for these on the inside. And sometimes you need some extra hormones during times of stress. So that's what it really comes down to.
And again, as I always say, in Happy Healthy Hormones, pages 326 and 27, you got to read the whole book. However, dosages and symptom alleviation and so on and so forth. And so, yeah, it was interesting to me, that we might have to titrate up some, titrate down some, because hormones might tend to fluctuate, and especially, with the fight or flight response, for sure, which you've taught me really, really well about. Thank you for that. And then the fifth question, we've done really well. We got through all the questions, not to mention the ones that have, okay, my Dutch test showed low estrogen, T, and DHEA. My progesterone is okay. I take progesterone 200 milligrams cyclically. Cortisol was in excess in the morning and a little in the evening. My functional doctor is starting me on adrenal support supplements and DHEA supplementation. Any thoughts about this approach? I have awful anxiety. I am 48 with perimenopausal symptoms, but still having a monthly cycle every 24 to 25 days.
The perimenopause. It's a wonderful and absolutely optimal time to take on the whole project of hormone replenishing. To your number one job is to find someone who really specializes in treating women in menopause, and finding that person, going shopping for that person, because that's a very important relationship, and learning some things yourself. And as you mentioned, you can learn from our book, Happy Healthy Hormones. The The great news is that you're getting disruptive symptoms and you're responding. You're starting to ask questions. What's going on here? And what do I need to do about it? And I want to get this right. And so there's no better time than the perimenopause. The challenge is that there's an erraticness to what is going on. For example, your brain and hypothalamus is recognizing that you're getting low in these hormones.
Right.
And it's almost as if the body is resisting this particular change of life. And when it senses that you're low in the hormones, it will put out a burst from the pituitary gland of a stimulating hormone to stimulate the ovary, to try and revive it. And you'll get that burst from the pituitary gland, and you'll get a burst from the ovary. But the ovary can't keep up the increased output that is being called to do. And what it looks like graphically, and I'll paint it in the air, is a young woman has, when you look at a month, at the beginning of the month, her estrogen levels are really low, and then they rise, and then by mid-cycle, they've reached a high peak, and that's when ovulation usually occurs, and they smoothly and gradually get a dip there at mid-cycle, and then they rise again to about 2/3 the length, and they gradually decline. A nice, smooth ovarian output that has a cyclical change to it. In the perimenopause, because of this erraticness, when the pituitary senses low estrogen, it might put out a spike of FSH, and you might get a peak of estrogen higher than you've ever gotten as a young woman. But then it can't keep it up, so you get a trough. And the pituitary stimulates again, and you get a peak and a trough, and you get this erratic output. So the goal in the perimenopause, from my perspective, is to replenish all the hormones. Certainly the estrogen. Your general hormone levels are low. They're lower than they've been in quite a while. So we gradually replenish the estrogen. We gradually replenish the progesterone. And in many cases, based on actual symptoms, we replenish the testosterone and the DHEA. And when we do a good job of that, that erraticness stops because the brain is registering, hey, there's enough in here, we're okay. Now, I mentioned all 4 hormones, and it sounds like the questioner is DHEA. Yeah, DHEA is going to be low in the perimenopause, that's for sure. And that's a good idea. But the principal hormones that are giving a perimenopausal woman trouble is her low estrogens and her low progesterone. And in some, low testosterone, especially those who've had a lot of stress in their life. So we replenish all those hormones. So I'm going to say it again. With estrogen, we want biased. Progesterone, we want progesterone. Testosterone, if needed, we want testosterone. So that's how I like to approach it. And a lot of how much and when can be determined by a very thorough medical history. Will give us the clues on the level of symptoms, and designing a gradual start low, gradually increase dosage protocol will alleviate these symptoms in an orderly fashion, hopefully most of the time.
Yes.
And you will not stave off menopause. With the levels of hormones that I'm talking about replenishing, it's not going to stop you from going into menopause. Your ovaries still will stop producing hormones, but it'll be a much smoother journey, and it won't be so abrupt and so symptomatic because we can alleviate symptoms along the way. So all 4 hormones, you're in the perimenopause. And yeah, it can be a little bit of a challenge for a woman in the perimenopause. However, what I always say to women is, when you master hormone replenishing in the perimenopause, even though you have to go through a learning process to do it, menopause will be a piece of cake. You'll be a master for your whole life. So you're in the training ground in perimenopause. And again, the great news is you're picking up on this in the perimenopause. This is the time to begin replenishing hormones. It's the best time of all.
Okay, so two question, Kate. That was my last question. I can't believe that we did that, and it's only 7:45. It's wonderful, and thank you so much for all of those answers. And yes, I take notes, and I hope women are taking notes. The book again is Happy Healthy Hormones, and it is downloadable free. Here on our group, The Ins and Outs of Menopause with David Rosensweet, MD. And you can send me a message if you want, and I'll send you the link. So the question is, what if you are perimenopausal, had breast cancer, and now have a prolapse of the uterus? What hormone can help this situation?
Well, there's a couple questions embedded in there.
Mm-hmm.
And let's take the most crucial one of all, if you've had breast cancer. And we highly recommend that you read the book Estrogen Matters by Avram Blooming and Carol Tavris, because this was published in September of 2018. The information is tremendously up to date. And it's really a major antidote to the false information that so many millions of women still believe about hormones, and so many healthcare providers do. And I'm referring back to the Women's Health Initiative that falsely alarmed the public by stating there was an increased risk of breast cancer, heart attack, and stroke if you took a hormone called Prempro.
Right.
Not Premarin, which was horse urine-derived estrogens, if you took Prempro. But in that original study was a statement that the relative risk was 1.26, and that was not statistically significant.
Right.
Not statistically significant in medicine means that there's no help whatsoever in that piece of information.
Yes.
And yet the press and the public misunderstood this, blasted it out, and stated that there was increased risk of breast cancer, heart attack, and stroke. Well, by 2006, in follow-up of these women, that relative risk had gone down to 1, which is no risk. And those of us who saw the initial relative risk and saw the statistically insignificant, we knew that there wasn't an increased risk, not something that we could scientifically rely upon. And the original Women's Health Initiative Study Committee that published that original paper in 2017 came up with a retraction. And they published that retraction in the same journal, the Journal of the American Medical Association. And I'm going to soundbite what their conclusions were. Women who are treated with hormones are at less risk for developing breast cancer, heart attack, and stroke than women who are not treated with hormones. And this is after 8 years of follow-up. That's their statement. So I would like any woman who's had breast cancer, we're all at risk for cancer. We're all at risk for 1,000 diagnoses for that matter. I wake up in the morning and I'm walking and talking and I feel grateful.
Right. Absolutely. You betcha.
We're all at risk for cancer too. As a male, I have a special risk for prostate cancer. And there's reasons for that. And as women have special risks for breast cancer and uterine cancer and ovarian cancer. And there's reasons for that. But even knowing that, women who are treated with hormones are at less risk for breast cancer, heart attack, and stroke than women who go untreated. And here's something else to know. Women who've had breast cancer and are properly treated for that breast cancer are at less risk for recurrence if they're treated with hormones than if they are not. And you'll get the details in Dr. Blooming and Tavris's book, Estrogen Matters, and I highly recommend you read this, and here's why. Every single woman I've ever sat in front of from 2002 on, whether she'll say it out loud or not, we've been able to elucidate a concern that if they take the hormones, they need the hormones, but if they take the hormones, they're putting themselves at risk for breast cancer. They're uneasy somewhere in there. And we're very proactive in the menopause method. In that very first consultation, we take this subject on directly with the patient because we want to bring it up and see if there's any lingering concern. And when there is lingering concern, we pause and we don't necessarily leap into treatment, because we don't want a woman applying hormones if she thinks she's putting herself at risk for breast cancer. But so many times that concern can be totally alleviated by having the information. And the main thing, if you're dealing with a healthcare provider that really has studied this, they'll know it. They'll know what the actual science is. They'll give you a version of something like what I said. And I find that most women, they just want to know that I know it, that I've done the research and I know what the facts are. And the science is, even though we're still at risk, we're at less risk for breast cancer, heart attack, and stroke, women who are treated with hormones. So that's where I'd like to start. And then there was more to that question. And yes, the prolapse. Prolapse. Well, prolapse of the uterus. And what happens when there's prolapse of the uterus is the uterus starts falling down from its position. It's held up in the pelvis by strong ligaments and a powerful muscle called the levator ani. And they hold that uterus and that bladder up in the pelvis where they belong. Then there's two reasons why that uterus can start falling down and the bladder can kind of falling down and even fall down and compress the vagina and even appear in the vagina and even prolapse to the outside in the worst cases. And it can be from sarcopenia, that's loss of the muscle called the levator ani, loss of most of it. And also those ligaments can get stretched in some childbirths. So there's reasons for prolapse. If it's just the sarcopenia, the muscle loss, the actual fiber loss and strength loss of the muscle that holds up the uterus, then you can certainly get restoration of that muscle through taking testosterone and DHEA and doing exercises in which you squeeze that muscle. Let's all squeeze our levator ani right now by squeezing our anus. Relax it, squeeze it, relax it. That has a funny name, named after Dr. Kegel.
Kegel, yeah.
It's you squeeze that muscle. It's a good muscle to exercise because it'll help you with the support of your bladder. But when I hear the word uterine prolapse, my guess it goes beyond sarcopenia of the levator ani. My guess there's some ligament stretch, perhaps in childbirth, and I didn't hear that from. So sometimes you're in the territory of a gynecologist, and they have operations, and sometimes there's a need for a hysterectomy, and that's one of them. When you can't cure that prolapse through strengthening the levator ani, and by the time it's prolapse, that's come a long way. Everything's healable, but this is the territory of at least getting a gynecological evaluation, because sometimes you need the hysterectomy. But I would never leave out the testosterone and DHEA for the preservation and even strengthening of the levator ani, and I would never leave out those squeezing exercises. One of my patients puts has a little sign over a toilet paper roll, squeeze.
Squeeze.
So every time she goes to the bathroom, she squeezes.
You can really do it anytime, any day.
Oh, yes. Anytime, any day. And it's really important thing to think about, because physicians who see the elderly, the women in their late 80s, early 80s, their 90s, we know that there's a series of things that happen very commonly, and loss of bladder control is one of them. So the preservation of that levator ani is a big deal. You really need the hormones to do it in most cases, but
you've often brought up that a lot of shelf space at the grocery store or wherever it is taken up by adult diapers. And sadly,
yes, it is, because a lot of women have urinary incontinence. They can't hold their urine properly. And just think how wonderful it would be to avoid that. And what it's going to take to avoid that in most cases are hormones. And the exercise that levator ani is important as walking.
Absolutely. Absolutely. Hormones and the levator ani and squeezing. Squeeze, squeeze, squeeze. It's not that hard to do, really, if you think about it. And it's incredibly helpful. I so sadly do see women, in their 50s even, wearing adult diapers. And I can't say any more about that. It just makes me really sad. A question
I'd like to answer, and it's as if you're menopausal and you start on hormones, will you get a period again?
I was just going to ask that. Yeah.
And the answer is, in my world, you certainly will not, because the dosages that you'll be receiving are not substantial enough or robust enough to get that period to return. Now, there are methods out there in which the hormone dosages are much higher. And in fact, there's regimens that even recommend the restoration of the period. And there's a lot of women on these particular programs. And I'd like you to know that to get that period to keep on going, or to reclaim a period that has stopped, it's going to take you between 3 and 8 times the upper limit of normal of a 20-year-old hormone levels to do it, estrogen, to do that. And that just has never made sense to me. But I want to get a little more detailed about it. Women vary, young women vary as to how much estrogen they have as part of a normal menstrual cycle. Some women need this much, and other women need more and have more. There's a range. There is no exact number for all women. There's a range. And you need a certain amount of estrogen, at least that much, to keep that period going. And for menopausal women, we say the ideal optimal zone is right below that you get all the benefits you need without getting what happens at the upper end. Because every single menstrual cycle in a young woman, the whole process preparing for birth occurs. Every single cycle. And if you don't get pregnant, you de-prepare at the end of the cycle.
Right.
One of the preparations that takes place is the forming of the endometrial lining. And another preparation that takes place, oh my God, you start preparing for breastfeeding every single cycle. And you get breast glandular cell proliferation. You get more breast glandular cells. You get mitosis of the existing breast glandular cells, cell division, and you produce extra cells. And the way a woman experiences this every cycle is her breasts get fuller. And then if you don't get pregnant, the breasts get less full, back to a different size. That's part of what a normal menstrual cycle is.
Right.
And dosages required to sustain a cycle, I say, put a woman at risk, and I'm not the only one who said this. I actually heard this exquisitely said by a reference that we have in Happy Healthy Hormones. You look up Alan Altman, the gynecologist, who comments on this, that the levels to restore a period, I assert, can put a woman at risk for breast glandular cell proliferation. We do not want mitosis and breast glandular cell proliferation in a woman in menopause. Even from one thing, our immune systems aren't as strong and able to pick up abnormal mutations that take place in cells. So at any rate, we stand very firmly and strongly on a strong opinion that women in menopause should not be given those levels that bring the period back. And in most cases, you don't need it. Now there is an exception. So you never say never in medicine.
Right.
And I'm going to tell the story again of a wonderful doctor who actually testified on the same panel that I did in front of the National Academy of Science. And she was 65, and she actually sat down next to me. And I had done research on who else was on my panel. And I learned about this doctor, that she was on a special approach to treating women in menopause in which she still had periods. And as she was sitting down and introducing herself, I asked her, "Are you going to mention that your period's restored?" And she winked at me and said, "No." And she did, because it's a very controversial approach to treating women in menopause, and it makes traditional doctors cringe.
Yeah.
And I think for good reason. Now, I went out to lunch with this wonderful physician and her son, and she told me this story, that her mom had dementia, and her mom's sister had dementia. That would be this doctor's aunt. And again, this woman was 65 when we went out to lunch. She said when she was in her early 50s and she was in her medical practice, she started having cognitive issues. And they kept creeping up on her, and they kept getting worse. And at a certain point, she was just desperate. She said, I'm afraid I'm going to have to give up medical practice. I'm not thinking clearly enough. I'm not remembering enough about my patients. And she's looking down the barrel of her mother's dementia and her aunt's dementia. And she was very concerned about this. And she started taking estrogen because she knew that there was a relationship to estrogen and mental clarity. And she kept on taking it, and she cleared up mentally. And she took so much, her period returned. And there she is at 65 having regular cycles. And my heart was so touched that she was thinking clear as a bell, certainly thinking as clear as I did. And I was so moved by her story that you never say never in medicine. And for her, getting those periods back, her intention wasn't to get her periods back, but her intention was to see if she could clear up her brain. And one thing we know from the medical literature, although it doesn't take very much to protect the bones and to protect the vagina, these are hallmarks of sufficient estrogen. What we can't say is the same amount is needed to help all women with cognitive loss. And what we know from the medical literature is that some women need quite robust doses of estrogen to keep thinking clearly. So again, in general, we do not recommend, in fact, we advocate against the restoration of the period in most women because of the possibility of putting breast glandular cells at risk for proliferation. But you never say never. Some women do need those robust doses, and we can monitor the breasts for breast health. And we do monitor the breasts for breast health. So I'm all for it. If you use the estrogen that you need to get that mind to clear up, it's so crucial. So there's a lot of moving parts to menopause. Maybe you all are sort of picking up on that. So it takes you back to your basic job. There's your job. Go out and find a specialist in menopause who really knows what they're doing, and they'll take care of it. And together you'll team it. And team it you will. You will need to team it. Any provider, especially myself, I'm 25 years doing it. I always hold any entering into treating a woman in menopause. We're a team, and we're figuring this out together, and we're figuring out the individual balance and dosages together. And we're very careful to do that together. And so you'll definitely be a proactive part of a good process, of an excellent process, but at the same time, you want the knowledge and experience.
Oh my God, it's such a beautiful thing to be able to team up with someone who is willing to team up with you, as in the doctor being willing to team up with you, the patient. You know, I mean, I can't think of a better team, I guess, to say.
I'm going to go a little bit over because we started a little bit late, and there's one more question that I want to answer there.
Thank you. Please be my guest.
Yes, it's maybe you want to read it to me. It's the one from Crystal. Can you see it?
If you had a blood clot, that one?
Yeah.
If you had a blood clot due to birth control pills, can you safely take HRT in menopause?
I'm not going to give you the short answer. And with all it takes is due diligence. The probable reason, the most highly probable reason that you got that blood clot is because you took the estrogen orally. It's well known, and the science on this is very clear, that topical estrogen does not have that same promotion of the coagulation issue. So it does not make you hypercoagulable. So theoretically, you should do fine with topical estrogen, but everyone should be taking topical estrogen, and that's the reason why. Now, we go a little further in the menopause method. I take a very careful medical history, and sometimes we'll do some coagulation studies whenever I'm in doubt. Because I have had patients who were on the birth control pill, and we put them on topical estrogen and progesterone, and they had blood clots, and they started feeling uncomfortable in their legs. And we start, just like as the patient commented to me, just like when I had my blood clot when I was young, when I was on birth control pill. So like anything with due diligence, you could figure it out. So what do? We do a sophisticated blood test done by one of the major laboratories in the United States to see, are you hypercoagulable? Now, we don't do that all the time. Many times we'll just treat with the topical estrogen because the medical literature is very clear that it does not promote coagulation. But because I personally have had the experience of even topical estrogen or with the progesterone gave a woman a discomfort like she had when she had thrombophlebitis, we'll go ahead and get a coagulation profile and see if someone is hypercoagulable or not. There are so many easy, natural, healthy ways to reduce coagulability through omega-3 fats, vitamin C, vitamin E. You can give someone so many of these wonderful supplements that they'll start bruising because they won't be clotting as well. In fact, I'll take some patients to the bruise level and back them down if I want to get their blood thinner. Moral of the story, there's definitely a way to do it. You just go through the due diligence to sort out your particular instance.
Got it. Can I ask you a question quickly? Is there a difference between bruising and petechiae?
There are different types of leakage
Bruising.
from the arterioles, but I need to sign off as I have a consultation.
Okay.
So as always, Carolyn, what a pleasure. And until next time, I'm going to sign off.
No idea. What a pleasure. Honestly, thank you for your kind time. Always, always, always enjoy your day. Please screenshot these to me. I have my